Good morning, everyone. So I'm Sabitha Bhagirathan, and I now work fully for Community Access Support Service, which gets called CAS. I never think that really explains very much about us. Our work is specifically around mental health in Bristol. We're a very small team. We try and tackle some of the stigmas around mental health and improve access to services, particularly among groups of people who don't often take up mental health services or seek support. So as an example, I coordinate the Black Asian Minority Ethnic Mental Health Network in the city. It's open to BAME, I use the acronym, led organisations. And my colleague David Anyinsa is doing some really groundbreaking work with men of African and Caribbean origins, getting them to talk about emotional well-being, and sessions called Black Men Talk. So that's sort of a bit of a snapshot of the work we do. However, this morning I'm here to talk to you about my former role at Wellspring Settlement, when I used to manage their chronic pain programme from September of last year. Wellspring Settlement is the new name as of February of this year. Wellspring Healthy Living Centre merged with Barton Hill Settlement. We're both based in the same area of Bristol, in Lawrence Hill. And we're now called Wellspring Settlement. So the work I was doing was for Wellspring Healthy Living Centre. And the Healthy Living Centre, when it was founded, was very much based on a commitment to social prescribing. So that's social prescribing is about GP referral of certain patients, particularly around sort of low level is probably the wrong term to use, but not very acute mental health, emotional well-being issues. So not something, for example, like schizophrenia that needs a lot more intensive support. And we have a team of social prescribers at Wellspring, including some who speak a number of languages other than English. So, for example, Polish, Punjabi, Somali. Referrals get one-to-one support, but then a really important part of our offer is lots of activities that we run in-house, for example, the chronic pain programme, but we also signpost to activities of partners all across the city. So I was managing the chronic pain programme as part of our social prescribing work, really. The programme was funded as a pilot by Sport England for around 2 years. The funding from Sport England ended in March of this year. And it was based on some research that had been carried out by GP trainees at Wellspring Surgery, which is downstairs at Wellspring Healthy Living Centre. So we work closely in partnership with them, as well as with other GP surgeries in inner, central and east Bristol. The GP trainees noted how many GP appointments appeared to be taken up by people who came in living with chronic pain for a whole range of different health conditions. And obviously the GPs, even prior to the NICE guidelines that came out this summer, GPs were trying to avoid the continual prescription of sort of opioid type medication for people with chronic pain, but there didn't appear to be anything else that they could really offer them. So we trialed this chronic pain programme. It wasn't open to self-referral. We took referrals from GPs across the city, but also from social prescribers, either at Wellspring or other partners, as well as other health professionals, for example, health visitors, physios, osteopaths, and so on. I coordinated the programme, which really comprised of a 6-week course, an hour-and-a-half session every week for 6 weeks, and those sessions were run by a qualified instructor who's amazing, Caroline Stevens, who came with a lot of experience. She's training now to be a physio, but she's a trained yoga, Pilates instructor, mindfulness type techniques as well, is what she already has under her belt. But I attended most of the sessions, or certainly would be there at the beginning, at the end. And before people joined, when they were referred to us, I did over the telephone just short assessments with them that gave Caroline a proper background of what people's issues and sort of capacity were. I also did a baseline sort of emotional well-being questionnaire that I then followed up at the end of the session. But I think the really important part of the one-to-one telephone contact I had with people was about building rapport, giving people confidence to come along to the first sessions. Because it was very clear, kind of even before we started it, that giving people sort of support around their emotional well-being, their mental health was really key for them to take it up and to keep coming and to follow it through. The sessions each week had a different theme. So, for example, nutrition or sleep, and activity was a core part of it. So it started off, Caroline was very clever. It started off with very short, say a 5-minute at the beginning, a 5-minute at the end, and all the activities could either be done in a chair or standing up. But it was amazing. By the end of the 6 weeks, there were usually sort of 20 to 25 minutes at the beginning and at the end, and most participants saying that they just couldn't imagine being able to do that in a block within an hour and a half session. We gave out some sheets that people could take away, very much encouraging people to do things at home. And the advice was very much, even if it's 2 minutes every day, don't worry about doing 20 to 25 minutes. But, very much embedding, living with chronic pain. So you're not curing it, you're not solving it, but living with it. If you can do activity every day, was going to help support you a lot better than relying on medication. And as well as the activity, we allowed time within each session for peer sharing if people wanted to. Not everyone wanted to, but that really did increase. And we found that really, people were saying how much that helped them as well, that they were with a group of people who understood. If they were saying, gosh, I cleaned my teeth this morning and then I was exhausted for 2 hours, the effort that took me, that they were with a group of people that they could articulate that with, who shared it. Sometimes shared tips, but often it was just sort of bearing witness, listening. I also then followed up. If someone said to me, I want to try swimming, but it's too busy, I would then look into when it was quieter at the local swimming pool. We signposted to activities either at Wellspring or to partners. And a really important thing that we could offer at the end of the 6 weeks, which went quite quickly, we were already running a gentle exercise class. So our sessions were free on the chronic pain program, but our gentle exercise classes that were either chair-based or standing exercises were only £1, and they ran all the time, and you could just drop into those. It wasn't the same as our 6-week program, but then quite often people buddied up and they started going to those when our sessions ended, and we got Athena, who ran those gentle exercise classes, to come along to the chronic pain program for session 6. So they got to meet her. She very much encouraged them to come, and she would give them a snapshot of what she did, and we would all do those exercises together. So that's how it ran before lockdown, before COVID made an appearance. And then as we then went into that first lockdown in March, our funding ended anyway. Then I managed to access Karen Lloyd from the Active Aging program organisation offered me the chance to become a consortium partner for a bid to St Monica's Trust to try running virtual activities over a kind of 12-week pilot session. Our chronic pain program wasn't only for people who were older, but with it being a pilot session, even though St Monica's Trust ideally wants to fund activities for people who are age 55 plus, there was kind of flexibility within that. And we were successful. I then moved to coordinating a program of virtual activities for a 12-week period. And one of the activities we ran was living with chronic pain. It was run differently from our 6-week program. People could refer themselves, as well as the fact that my social prescribing my social prescribing colleagues were all then moving to offering their support over the telephone. They then were referring into our program, and the GPs were referring to us as well, but people could self-refer, and they were drop-in sessions, so you didn't have to commit to a 6-week program. We only ran them for an hour because we felt an hour and a half over Zoom was just too long, and because they were open to drop-in and self-referral, we felt the speaking parts, the learning parts that Caroline used to do on our 6-week program probably didn't fit in that well, and we didn't know whether people would want to share as much as they used to together in a class over Zoom. But what we did have was that people knew that I was there as a contact if they wanted to ask Caroline a question. So Caroline ran them again, which was fantastic, that we could keep that partnership with her, because obviously all our former instructors lost their income when we went into lockdown. So it was a way of continuing to have that kind of asset base in our partners who are freelancers. not losing them completely. But people could email me with questions to ask offline, you know, if it was a particular health condition they wanted advice on, that I could then share with Caroline. And the feedback has been amazing. That pilot has ended. We're hoping to secure some funding to restart them. The take up was really excellent, and we found that another one of the sessions I was coordinating, we trialed Qigong, and we found quite a lot of people who identified as living with chronic pain started going to both of them. Also found that some people were taking up the offer who had never accessed anything virtually before and hadn't even had email prior to lockdown. So maybe a family member had set up email for them. And what I offered was a kind of talk through bit of support at the beginning, that I would have people on the telephone, or I would do some trials, sort of Zoom links, and show people how they could access Zoom. And that really opened up for a lot of people. And one woman particularly, it felt really positive and such a success story, because she was living with quite a chronic condition. She's actually had an operation more recently, but she was then able to have kind of GP consultations virtually, having had the confidence to join our living with chronic pain sessions and the Qigong. We also offered singing for wellbeing as part of that program activity. She joined that as well, even though she'd never done any singing before. And people were really saying to us that they felt such a connection. They didn't think that virtually through a screen would be a way that they would make new friends or feel able to talk about the pain that they were living with or how their emotional well-being felt. But people started coming regularly, and Caroline just managed the sessions very well. She's also someone who lives with chronic pain, and she's very open about her health conditions and how she was maybe having flare-ups because of anxiety, and that, I think, really massively helped how our sessions gelled, despite the fact that we were boxers on a screen. I need to keep an eye on the time. I think I'm okay for a little bit longer, so I'll go into a bit more of just to give you a bit more of a snapshot of numbers. When we were running the real life 6-week program, I used to book on about 20 people to the program, and they were filled up quite quickly in advance, and I would have a waiting list. But what we did find was when we were running the program, probably about 10, at the most 12 people came maximum, but that was kind of what we were aiming at, so I always tended to overbook. But we would find that for an hour and a half session of coming together, and particularly as I was saying, we would always allow time for people to share experience, that 10 to 12 people coming regularly was sufficient. And it was very much a sort of non-medical model. We had some feedback from people who had gone to other chronic pain sessions that were based in hospitals, so living with chronic pain that were based in hospitals. And I think already the fact that you're going into an environment that's like that, kind of white corridors and tube lighting, gives a particular flavour from the beginning. Whereas Wellspring Healthy Living Centre, if anyone had ever been there, a very colourful place. Our walls are covered with artwork that are produced by people who go along to our art therapy sessions. We used to have, in the days before COVID, we used to have pom-poms hanging off our banisters, and the sessions and the exercise studio where we run the living with chronic pain sessions and gentle exercise and so on is a very warm environment. We can close curtains if people want that privacy. And it's a very sort of non-medical looking building that's obviously fully accessible. And then thinking about the sessions, once we've moved to running the sessions on the virtual hub, I did have some feedback from a participant who had started going along to sessions run by Vitaminds that was set up specifically around emotional well-being for living with chronic pain, and he'd waited quite a long time to get a place at those sessions. He found those, the focus of Vitaminds is different from ours. Ours was very much activity based, but he found with the Vitaminds sessions, everyone was muted, and you could only pose questions in the chat, and maybe that's because there were larger numbers of people, and maybe because it was emotional well-being, mental health focused. perhaps around privacy and confidentiality, it was felt it was needed for that. However, for him, the way his health condition means he can't type. So he said that actually it was really tragic to hear that his mental health basically felt lower from going to those sessions for him specifically, because he felt very silenced in them. He couldn't share anything, he couldn't type. Whereas with our sessions, he didn't, he had free reign, he could speak with all of us. So that's obviously one person's very specific health condition and how that was for him. So obviously, we're aiming as colleagues to have a breadth of support available for people. Thank you very much for your time, and I look forward to hearing from the next speakers.
Savita, thanks ever so much. That was so helpful. Before you go, can I ask you, just because I know you can't join us for the workshops, your top tip about our resource hub? You've talked about a very physical presence. What would you recommend that how we provide resources to people about chronic pain?
I mean, I think I've learned so much from Caroline, and what she puts across is, she's just amazing, that she's very open to how she lives with chronic pain and what she does with that. And it's about that there isn't a cure, and without being bleak around that, but it's very much our conversation of how our premise was you're living with it, and there'll be ups and downs, and that emotional well-being support to give resilience with the ups and downs is what's really important. And I think, that honesty around that, making people then stick with things rather than, oh well, I've tried these exercises and I was still in pain the next day, so I'm not going to bother coming back. So it's trying to get messages across that. And I think the partnership work, I mean, we had such an ethnic diversity and age diversity and kind of demographic diversity across the city, people's sort of socioeconomic backgrounds. There was such a diversity of our actual 6-week program of who came along. And I think that establishing the referral routes from a diversity of partners really helped that. And I think that's really important. And I think that's something we're really learning around chronic pain and long-term fatigue, for example, because of COVID, long COVID. It's, particularly impacting on people from certain Black, Asian, minority ethnic backgrounds, from certain socioeconomic groups, more, say frontline workers who've maybe had, impact really affected by lockdown and so on. And so it's making sure that it's as accessible to groups like that. And when you see yourself represented amongst the group and instructors, and through partnership routes. So for example, Nilari is an organisation I work with a lot from CAS. Nilari signposted people to us as well, Bristol Black Carers. So it's establishing those strong partnerships to get the diversity of take up.
That's really helpful. Thank you so much. Really grateful.
So, as Candy's just said, I work in the CCG, and most of what I do is around pathways of care and also referral processes. And most of that we host on a website called Remedy. Can you just move to the next slide, please, Kirsty? So Remedy is purely a website, really, but it's been designed and put together locally as part of the CCG. And it's updated and maintained by myself and Dr. Rob Adams, who's one of the GPs who's the clinical lead for the referral service. So as well as being a GP, he also sees a lot of other GP referrals and has that breadth of knowledge of what kind of referral activity is going on across our area. So Remedy is aimed at GPs, but also medical secretaries and other practice staff. And it's definitely not intended for public use. So it is a website that doesn't need a login to get into. So in theory, anybody can look at Remedy, but certainly in terms of content, it's not designed to be for the public to consume, if you like. And then in September 19, we actually added the BNSSG formulary to Remedy as well, which makes it a bit of a go-to place now for both primary care colleagues and secondary care. And the next slide, please. So when we're developing information for Remedy, we'll work in conjunction with whoever we deem as the clinical expert, if you like. So that could be consultants in the acute trusts, it could be our community providers, it could be with public health teams in the local councils. And of course, we also commission other services such as drug and alcohol services. And so we'll work with a whole range of people to pull the information together. We'll also include information on self-care and the voluntary sector, if that's appropriate. And once we've got to a stage of having that information in the format we think it would be able to sort of publish, if you like, we'll then arrange for it to be signed off by those expert clinicians. So if we've developed information with one of our acute trusts, so say with North Bristol Trust, we'll then try and also get agreement from University Hospitals Bristol as well, so that is across BNSSG that guidance applies. We then arrange sign off by our internal CCG teams, and that could be the commissioners or the funding team for certain referrals that require prior approval, and also our medicines optimization team to make sure that any prescribing guidelines are in line with the formulary and with their advice. And our final sign off is by 2 to 3 GPs who are really our main audience, if you like, and we send it to them just to make sure it makes sense from their point of view, that they don't have any additional questions, that there are no contradictory bits of information in there that they'd like clarified. And the next slide, please. So we've tried to go for a standard layout on Remedy. We're not there on all pages yet, because obviously this is a bit of a work in progress. But we start off really with who to refer, what are the red flags, before referral, what should happen in primary care, or in some instances where there is nowhere to refer anybody, what sort of management activity of that person's condition should take place in primary care. We then talk about the services that are available, whether that's in the acute trusts or the community, any referral criteria and the actual process of referring. And finally, we have a resources section, which will be links to any other websites or further guidelines, patient information leaflets, any of that extra information that people might want to look at. And the next slide, please. So I thought at this point we'd just flip over to Remedy and let you actually see what it looks like. If you could open the front page, please, Kirsty. Okay, so this is the initial login page, and then we have a drop-down menu on the side there. So we're just going to have a look at the pain information that we have on Remedy. So if we just open up the adult section, and you'll see that's split by speciality across the health service, and we're going to just open the pain management and CFS and then pain services. So this is the page that we've developed around pain. And again, it starts off with who to refer. And I think we've tried to make it quite clear on here that, as Sabitha said earlier, often pain clinics can't resolve people's pain. It is more about helping people to be able to live with that pain. And so if we could just roll down slightly, Kirsty. So under referral to the pain clinic, we've introduced both a pain referral proforma and a pain patient questionnaire. And both of those documents are about really identifying what the person's pain, where it is, how often they experience that, but also about helping them to realise what the pain clinic is actually going to offer before they get there. So it's really about kind of managing expectations. And then if we just scroll down, we've identified the red flags for pain, and also some yellow flags, which are the sort of psychological issues impacted with pain as well. And then if we go further on down, before referral, we've given various information there on strategies for keeping mobile, helping patients keep active. So again, reflecting a lot of the things that Sabitha was saying. And if we go down just a little bit further, we've given the pain clinics at the 3 trusts, but also in the resources section, we've given both resources for medical professionals, but also for patients as well, including some YouTube videos in there. So certainly talking to Martin Jones, who's one of our GPs, our GP medical director, and he was saying that often GPs run out of options for people with chronic pain, and that if there are things that we could include that maybe non-pharmacological and evidence-based, certainly it would be useful to add this in as well to Remedy. So I know from talking to colleagues at Dorothy House that they're looking at pain as part of palliative care. So I thought we'd also just have a quick look on Remedy under some of the other sections that we have here. So if you just want to scroll back up. So one of the sections we have off the main menu is cancer support. And then under the LWBC, which is living with and beyond cancer, there are resources from GPs, which includes some useful services and also advice on specific conditions. If we could just scroll down a little bit more. Keep going. A little bit more, that's it. So we've given the MBT Macmillan Wellbeing Service there. We've included advice on specific conditions such as managing fatigue or managing heart health, and certainly we may well link to the pain information that's being put together from Dorothy House as well. Okay, so if we could just go back to the next slide, please. Ken. Next one down. So Remedy, it's extremely popular across BNSSG. We roughly have 70 to 80,000 page views per month, and I think the last count in October was about 120,000 over the month. So we're looking at 3,500 page views per day. And I did look up specifically the pain information. And again, roughly 7 times a day, we've got people out in practices looking at that information. So as I said, very popular resource. And then the next slide, please. So this was just some comments from some of the GPs across BNSSG when we surveyed them on Remedy. And I think probably the main selling point is that all of the practices are all looking at the same information. They're all looking at the same referral criteria and where and how patients should be treated. So through that, we're trying to reduce some of that variation in referral thresholds and quality of referral. And then the next slide down again. Please, Kirsty. And this, obviously pain is just one small aspect of what we do on Remedy, because we literally cover pretty much all conditions, everything that GPs see. And this is some of the other things we've been working on since March. Obviously, COVID had a huge impact on us. Various services were closing, we're changing the way that they could be accessed. So we did a lot of work around that. Obviously, things like the voluntary support in the community. And then our standard sort of work, including endometriosis or rhinosinusitis. And anosmia was obviously very COVID linked as well. And also we deal with pediatric pathways. So we do a lot of things on Remedy, and pain is one aspect of that. So really, any questions, if anybody had any questions about Remedy?
Perfect. Thanks so much, Vicky. That is such a fantastic resource and such a great place for us to be starting from. And I can see that, as you said, if it is accessible to all, that even though it isn't directed for patients, it may be really helpful for those based in the Bath area to be able to look into that as healthcare professionals. So that's fantastic.
So yeah, I mean, we've just heard about fantastic professional information that's out there, but I just wanted to start by highlighting, not that I think anyone isn't aware of this, but there is also a lot of patient-facing information out there. So this is the kind of central NHS website, and what I think is interesting there is pain and pain management don't occur in their health, A to Z. As Savitha was saying, it's very much part of the live well section and about that kind of lived experience and how they guide people through that, rather than kind of looping back to the source conditions, which I thought was interesting for us to know. Next slide. And then, what there are also available are kind of a range of resources that are accessible in different ways. So this was something that was created by a spin-out social enterprise from Torbay and South Devon NHS Trust. I mean, this is just the pain section. There's a broad spectrum of conditions, but what there are is patient-facing videos that help talk through conditions, available through an app if patients want to access those. And then that app also has built-in functionality around booking patient visits and appointments, depending on the nature of the services being accessed, that can be bolted on as well. And so, I guess in looking at this in the widest context, one of the key questions for us is how we build on all of these resources, the professional and the patient facing, to produce something different. So next slide. And clearly what we need to do, notwithstanding the fact that a lot of good work has already gone on, is find our own approach. So what you can see is Jen and I starting to kind of sketch and just kind of wrap our own heads around how we lay these things out, looking at some of these examples, to make things as accessible as possible. Now, the approach that we're taking to start with, sort of working with Candy, is to think about chronic pain in a palliative context, because that's obviously where Dorothy House has a key interest and where we have a gap to plug in our own resources as well. But what we're really hoping is that this will be a pilot project, and it will give us a template and allow us to learn lessons that we can take through to something that covers all aspects of chronic pain on behalf of the HIT. And so, so what we really need to thrash through is how we identify those top line bits of information. If you click on one specific category, what that takes you onto, how you then access and find the resources that might sit underneath that, and also information about what services are out there. So is there a guide to a clinic? Are there downloadable information sheets? Are there videos that you can access? And really trying to bring all of those things together into one place. Next slide. So for the pilot, as I say, that's about palliative chronic pain alleviation, or palliative and end of life. I think from the conversations we've had previously, we're really clear that we need a multimedia approach, that there are multiple audiences for this. So we talked about professionals and research and patients, or those living with conditions, and that's the basis of some breakout groups we're going to go into in a minute. But I think for us, also working on some of the things that sit underneath this. So, how are all of these things tagged so that they're easier for people to find? Are we talking about content that's actually hosted on our hub, or are we talking about pointing off to external places, very, very possibly places like Remedy? So there might be a two-way integration between some of these key things that already exist, so we're not reinventing the wheel at all. As Vicky talked about very clearly, things like the sign-off procedure are really important, and keeping the content up to date. Assuming that we're kind of using the tool itself in order to let us know what the need is, using things like Google Analytics to see what pages people are visiting of those that are created, and also reviewing things like Google search terms to try and find out what it is people are looking for that we're not yet providing access to in our field, of course. And what we'd like to do is move something forward to launch next month. Now, clearly that's not even within our tiny subset of palliative and end-of-life chronic pain. We're not going to achieve that a complete solution, but what we really want to do is get something available so we can start learning lessons by people visiting it, finding what's there, seeing what's working and what's not, and asking for people's feedback around that. Next slide. So we're going to break into groups in a minute, and there's kind of this subset of a pilot project that's specifically relates to Dorothy House's work as overlapping with the HIT. But clearly that's not the skill set of everyone who's on this call today. So what we really want to identify from these sessions is how we move forward as a HIT. So, the questions we've been asking ourselves in reviewing and thinking through this pilot are, how do we have the biggest impact? Actually, if we can't do absolutely everything, where is it that we're going to improve what professionals and clinicians have access to, perhaps, or the lives of patients, the lived experience? What is that place where actually we make a meaningful difference? And so within that, obviously, it's really important to be clear who our key audiences are, who are we writing this for, and what are their needs? How are each of those groups different, and how do we need to serve them differently? Thinking about what's out there already and what gaps we should be filling. Where we can collaborate with others, and clearly we've heard some great examples this morning of things that we really must find ways to stand on the shoulder of and add value to, rather than trying to reinvent, because people like Vicky are clearly already doing a fantastic job in offering really important resources. And then this question of the integration. If there's some of our own content there, how do we keep that up to date? If we're borrowing other people's content, how do we know that it's up to date, particularly if we're moving that within the context of our own hub? So really, it's really important that we tackle those. So I think we're going to have a little break, and then each of the facilitators for the groups will be asking some different questions to try and draw that out. But hopefully that gives a sense of the thinking that we've been doing and what we're trying to achieve. I've tried to do a quick version of that to make back a little bit of time. But if anyone has any questions before we go into that break, then do ask.
Thanks very much, James, and thank you for sorting out my poor chairing. It's most grateful. That's really helpful, and you've given us some really good pointers to go into our.
I hope you all enjoyed that 30-minute breakout session, and certainly our room was coming up with some fabulous ideas around our particular theme of research. So I'm aware that we're quite close to time, but very briefly, if each of our facilitators from the breakout rooms could just give us the sort of highlights from their particular discussions, that would be really helpful. Thank you. Who would like to start? Jem, would you like to have a go? Thank you.
Really great group, so thank you. I think what really came across is lived experience, and having the balance between having information and actually having the understanding of somebody who's experiencing that, actually talking through. And we talked quite a lot about explaining pain, the difference between acute and chronic, and getting that right. So really, really helpful. And mood. So we did actually manage to come up with, a set of kind of 5 categories that we can take forward, which I won't go into now because for time. But I think, and I think that the it's not about treatment came across very carefully, and that we have to have a real balance about, what's out there for referral and treatment, and not trying to take away from that, but learning to live with. So that was what we came up with.
It sounds like you covered a lot of ground in 30 minutes, so well done. Thank you. James, would you like to tell us about your breakout room, please?
Yeah, absolutely. And for us, we certainly talked about that knowing of the patient and how important that was. But really, we were focusing on that there's a lot of good work being done by various bodies, and a lot of new roles being created to be the delivery agents of those. and how significant it is to make sure that we have a resource that gives a shared knowledge point across all of those professionals and those people that are in that kind of front line of contact. And so trying to understand what all of those initiatives are, what the opportunities they bring, and then having one information site that brings those together is hugely important, and making sure that the kind of the knowledge that's there is actually reaching out and getting to the people. So, you know, I think my favorite comment of the whole thing was not knowing what you don't know. So, you know, really making sure that it's not just a hub for information that you already know exists, but you just need reassurance on, but actually is giving you access to things that you wouldn't otherwise know to access, feels like a very important part of what will make this initiative important and valuable.
Yes, it's one of those points you mentioned earlier about how can we have biggest impact, and it's by providing perhaps that information that's one step further than what's currently available. So yeah, thank you for that. And Ed, would you like to feedback please from your breakout room on research?
Yes, I certainly can. We had a very active discussion around research and how to what sort of types of resources to put onto the hub. I think one of the key things was that we were thinking about was, first of all, the type of evidence and type of information that might be out there. So it's information provision, but also think about how you conduct and facilitate research collaborations. What underpinned all of this is really having really clear signposting, both in terms of information provision, because it can be quite overwhelming, and understanding the sort of different levels and qualities of evidence, but also making the resources quite engaging. So, you know, just a long list of lots of research papers may not be that interesting for lots of people. So making it really, and one of the, I think the neat ideas was actually, we heard, well, I certainly heard multimedia towards the end of the session. And so we were thinking, well, we could have, you know, little video clips of people who've either have just finished their research, you know, big research projects, and talking about what the key things they found, but also people who participated in the research themselves, and actually why they got involved in research and why they thought that was of benefit, etc. So actually giving the different perspectives, but short little video clips which might help people understand why research is key and underpins what we're doing. There's also talk about how to make, you know, how to bring people into a web page and a hub like this, and we've certainly sort of had some interesting discussions around celebrity endorsement and things along those lines. And actually, you know, having someone who's recognisable, who can bring you in or bring people in, might be quite a neat thing to start thinking about. So whether there's somebody regionally who we could perhaps go to just, you know, sort of help promote what's going on here and why it might be of use. In terms of the research collaboration side of things, again, and then I think it's linked to this. I mean, part of the getting the information out there may also be around the research projects that are going on, and thinking about how we do recruit into these, and whether there's a sort of way of, you know, sort of advertising the sort of research projects that are going on and the opportunities to get involved. And then there was other discussions around, you know, getting things much more interactive, so social media, those sorts of things, and the use of health professionals to help in terms of recruitment.
Thank you. That's really useful. So it sounds like we've had some fabulous discussions this morning. We've also had some brilliant presentations. And as we create our information resources going forwards in terms of the Chronic Pain Hub, we'd really like to continue to hold these sorts of meetings. Unfortunately, we haven't got time today for any more discussion, but we'd like to continue to hold these sort of regular, short but sweet, impactful meetings going forwards. And we'd really appreciate your guidance as we continue to work on this and to shape these various aspects of information resource around chronic pain that we can provide to our region. We're out of time, so it just leaves me to say really huge thanks, firstly to you all for attending today and for your contributions to our breakout discussions. Huge thanks to Sabitha, to Vicky and James, who are our speakers, who gave some fascinating insights into work that's already happening. To our facilitators, Jess, Ed and James, again, thank you for chairing those sessions and for pulling those informations together. And to Charlotte and to Kirsty for organising this event and making sure that it's all run so brilliantly smoothly. Huge thanks. If it were left to me and it was a technical issue, it wouldn't have happened. So yeah, absolutely huge thanks to Charlotte and Kirsty. And I'm sure I speak on behalf of Candy and myself as well to say just grateful thanks to you all. We'll stay in touch. If you'd like to get in contact with us, you've got our email addresses. Please do. If you're reflecting on this event, you want to offer any other suggestions or things you wish you'd said, please do get in touch with us. We will get in touch with you through our regular updates, and we'll be hoping to hold another one of these sessions in the new year. Thank you very much indeed.